morning all. Ma'am, Dean ma'am, Rohit Gupta sir, Abhishek sir and Meenakshi ma'am. I first of all I would like to extend a warm welcome for all of you gathered here for the CPC section today. And this is a rare case discussion and this is a classical case of multidisciplinary collaboration. So today I will assure you that this is a great clinical lesson for all of you. So our case discussion is started by first the clinical manifestations and discussion by Dr. Joyson, Senior Resident of Department of Otorhinolaryngology and Head and Neck Surgery Department, and the radiological investigation is presenting by Dr. Priya, Junior Resident from Department of Radio Diagnosis, under the supervision of Pankaj sir and Rahul sir. And the histopathological section was presenting by Dr. Bhartendu, Junior Resident from Pathology Department, under supervision of Ashok Singh sir. And the whole case discussion CPC was under supervision by Dr. Abhishek sir, Associate Professor from Department of Otorhinolaryngology and Head and Neck Surgery. So without any further ado, I would like to invite Dr. Joyson, Senior Resident from ENT Department, to start the CPC session.
Good morning all. Myself Dr. Joyson, Senior Resident, ENT. Here I am going to present a case of a 35-year-old male patient. He is a driver by occupation, came to ophthalmology OPD on 19th of April 2022 with the complaints of protrusion of both the eyes for the past 3 months, which was insidious in onset and gradually progressive in nature, associated with the watering of eyes and redness of the eyes. There is no history of blurring of vision, double vision, photophobia, headache or ocular trauma. There is no history of comorbidities or no history of any addictions. On ocular examination, the best corrected visual acuity was normal, 6/6 pars on right side and 6/9 pars on left side, which was improved to 6/6 pars on pinhole. And extraocular muscles were restricted in all cases in both the eyes. Hertz exophthalmometry shows 26 mm exophthalmosis or proptosis in right eye and 27 mm proptosis on left eye. The fundus shows grade 2 papilledema. Based on the clinical scenario, we put there was a differential diagnosis of in tumors including lymphoma, Ewing's sarcoma, and thyroid diseases and thyroid eye disease and inflammatory conditions like pseudotumor, Wegener's granulomatosis, histiocytosis, Sjogren's syndrome, and fungal granuloma. Patient came with an imaging of CT brain and orbits, which was done outside on 11th of April, which shows hyperdense lesion in the retrobulbar region encasing bilateral optic nerve. The films was not available. Then from ophthalmology department, CE-MRI brain and orbits done on May 18th, 2022. The radiological part will be discussed by radiology resident.
Good morning, respected teachers, leaders, and my dear colleagues. We'll now discuss the radiological aspect. In short, we have a 35-year-old male who was presented to us with bilateral exophthalmos, and his systemic examination is completely normal. And he has got a CT report from outside which showed hyperdense masses in bilateral orbits in the retrobulbar region, encasing bilateral optic nerves. And in suspicion of lymphoma and to rule out any other intraorbital pathology, we have done a CMRI of brain and orbits in the month of May in 1.5 Tesla MRI scanner. And these are the actual images of brain and orbits. The first image, this is a T2 weighted image, and the second one is a T1 weighted image, and the third one is a diffusion weighted image. And in these images, we see bilaterally symmetrical retrobulbar masses in orbits, encasing bilateral optic nerves. And these lesions are hypointense on T2 weighted images, these are isointense on T1 weighted images, And these masses, they are causing bony remodeling of the orbits and are causing exophthalmos. And these are coronal images of bilateral orbits. The first image is a T2 weighted image, and the second image is a post-contrast image. And in the T2 weighted image, we can still appreciate the retrobulbar masses which are encasing bilateral optic nerves. We can still see the preserved optic nerve sheath, CSF sheath around the optic nerves. And you can also appreciate the involvement of lacrimal glands here. Lacrimal glands, they are usually T2 hyperintense. But here we can see T2 hyperintensity in the lacrimal glands, and they are bulky, bilaterally symmetrical. And just below the orbits, we see the maxilla, and just later to the right maxilla, we can see the buccal space here, and there is T2 hypointense soft tissue infiltration in the buccal space. And on post-contrast images, we can see homogeneous post-contrast enhancement of the retrobulbar masses, the lacrimal glands, as well as the buccal space soft tissue.
The nasal cavity should be used on that side. Nasal cavity.
Ma'am, this is the nasal cavity. This is the inferior turbinate, ma'am.
So it is from both sides. Is it normal or abnormal?
Ma'am, this is mucosal hypertrophy because of the DNS towards the left. The patient has got mucosal hypertrophy on the right side.
There is no infiltration.
No infiltration, ma'am. And these are axial images, axial T1 post-contrast images of head and neck spaces. And here we can appreciate soft tissue infiltration, homogeneously enhancing soft tissue infiltration in the masticator space, the pterygopalatine fossa, and here in the buccal space. We can also appreciate the infiltration in the maxilla here. And in these axial sections, we see the mandible. Here we see homogeneously enhancing soft tissue infiltrate in the mandible, as well as in the mandibular canals. And there are missing teeth in this patient. The premolars and molars are missing. On further inquiring the patient, he gave a history of painless tooth loss, which started 2 years back, even before the proptosis. And these are coronal images of the brain. This is a T2 weighted image, and this is a T1 post-contrast image. And here we see bilateral occipital lobes, the tentorium cerebelli and the cerebellum. Here we can appreciate a dural-based lesion, which is T2 hypointense and showing homogeneous enhancement on post-contrast images. Based on all of these imaging findings, we have 3 differentials. The first differential is an IgG4 related disease because of the characteristic T2 hypointensity of all the lesions, and also the involvement of orbits and the head and neck spaces. And the second differential was the orbital lymphoma because of the bilaterally symmetrical retrobulbar masses, and neural lymphomatosis was considered because of the head and neck space infiltration, which was along the mandibular nerve distribution. And the third differential was of pseudotumor. But this is a less probable differential because pseudotumors, these are usually painful conditions and they're asymmetrical. And so further histopathological correlation is advised for this patient. And now further course will be
More as the first differential and not a lymphoma. That is rarer than a
yes ma'am. Lymphoma, it is more cellular, ma'am. And on DWI, we can appreciate diffusion restriction in case of a lymphoma. But here we do not appreciate significant diffusion restriction in this case. And then also lymphomas are characteristically T2 hyperintense, ma'am. And all of these lesions in the orbits and head and neck, these are T2 hypointense. So that was more suggestive of an IgG4 related disease, and also the involvement of head and neck spaces.
Any other evidence in the rest of the body of IgG4?
Ma'am, in the next MRI and then in the CT test and abdomen, we have got evidence. And now the
thyroid, that exophthalmic goiter has been excluded. The accumulation of the mass that is causing protrusion.
So in case of goiter, we will see enlargement of the extraocular muscles, sir. But here we just see a soft tissue infiltrate, which is infiltrating the muscles. But as such, we cannot see any enlargement of these muscles, sir.
There is a differential of pseudotumor as well.
Yes, sir, there is differential pseudotumor. Pseudotumor is due to hypointense, yes, sir. But pseudotumor doesn't present as symmetrical masses, retrobulbar. It is usually asymmetrical. And also unilateral, most common.
This nasal cavity on the right side, this certainly is obstructed. You know, the whole of the right nasal cavity is obstructed.
Yes, ma'am, that is because of the deviated nasal septum towards
Whatever
the...
it is,
Yes, ma'am.
you can't rule out.
Yes, ma'am. Yes, ma'am, it could also be an infiltration, but that is not enhancing on post-contrast images. Now, the further course will be continued by Dr. Joyson.
After the imaging, we worked up for biopsy under GA. Patient admitted under ophthalmology on 30th of June 2022, and bilateral lateral orbitotomy with incisional biopsy under general anesthesia done on 1st of July. The histopathology report came as lacrimal gland hematoma. Then patient was kept on follow. During follow-up period, patient got symptom progression, and patient readmitted under ophthalmology on 15th of August. On readmission, on examination, the Hertz ophthalmometry shows 28 mm proptosis, which is severe, with a restriction in all cases. Then patient underwent right side lateral orbitotomy with the mass debulking plus excisional biopsy under general anesthesia under guarded visual prognosis on 17th of August. During post-operative period, patient started on injection dexamethasone and cefotaxime. Post-operative period was uneventful and patient was discharged on 20th of August. And patient was kept on follow-up. Patient histopathology came as hematoma. And CMRI brain with orbits and whole spine screening done on 18th of September 2022. Radiology part.
Contrast enhanced MRI of brain and orbits as well as whole spine screening was done in the month of September, and to look for any progression of the disease. And here we can still appreciate there is no significant increase or decrease in the size of the lesion except for a post-op changes in the right orbit. And also the dural based lesions, they were of the same size, and there are no new lesions seen in the brain or in the head and neck. And we can appreciate these soft tissue enhancing infiltrate in the bilateral head and neck spaces and the mandibular nerve distribution. And also we can see the soft tissue infiltrate in the head and neck spaces as we have seen previously, and there is no change, any significant change in the vertices. And in whole spine screening, there was no significant abnormality in the whole spine, and this is a coronal stair image of bilateral sacroiliac joints, and we can see hyperintensities in the end planes of the sacrum as well as bilateral ilium, indicating bilateral active sacroiliitis. And now that we have a histopathological diagnosis, that is with gold standard we consider as hematoma, we gave a diagnosis of neuromuscular choristoma because of the T2 hypointense bilateral symmetrical lesions involving orbits. Neuromuscular choristoma arising from any of the nerves in the orbit region, and the head and neck space lesions, we have given it as desmoid-type fibromatosis, which is a close association of neuromuscular choristoma. But NMC with DTF, this is very rare in head and neck region. This is usually seen in extremities. So further immunohistochemistry and histopathological correlation is advised. Now further course will be continued by Dr. Joyson.
During the follow-up period, patient again got the progression of the symptoms. The proptosis was enlarged too much, and patient readmitted under ophthalmology on 5th of November. On ocular examination, there was thinning of the cornea and superficial punctate keratitis was present. Extraocular movements were restricted in all the cases. Left eye medial tarsography done on 5th of November. And ENT opinion done for extension of mass into bilateral pterygopalatine fossa, masticator space and buccal space on 7th of November. Examination findings on nose, there was anterior DNS to the right side and posterior DNS to the left, and bilateral middle and inferior turbinates appears to be normal. Examination, neck examination and ear examination are unremarkable. Patient underwent bilateral endoscopic sinus surgery with the septoplasty with endoscopic assisted orbital decompression with biopsy under general anesthesia on 10th of November. Here we can see we will be going through the nasal route, and on the lateral side we will be getting the medial wall of orbit. The mucosa is elevated and lamina papyracea is, through the lamina papyracea we enter the orbit, and through the orbit we took out the mass for biopsy. During surgery, the lamina papyracea of the left side was found to be partly dehiscent, and biopsy was taken from masses in both extra and intracoronal tissue compartment, exposing the medial rectus and the superior oblique. During the post-operative period, rheumatology opinion was taken. Rheumatology opinion taken, and they put a differential bits of IgG4 disease, ANCA-associated vasculitis and tuberculosis, and advised to do multiple investigations. C-reactive protein quantitative that given 68 milligram per deciliter, 24-hour urine protein and creatinine it was 136.8 milligram and 504 milligram. Serum IgG4 1083 milligram per deciliter, and which was normal. IgG4 stain in biopsy was negative. P-ANCA and C-ANCA was negative, and advised CCT chest and abdomen. CCT chest and abdomen done. The radiology part will be discussed.
Was it just X-ray done? That should be short.
Contrast enhanced CT of chest and abdomen was done in the month of November. This is axial section of the abdomen at the level of kidneys, and we can see bilateral, symmetrical, enhancing soft tissue infiltrate in the perinephric spaces as well as in the renal sinus. And the soft tissue infiltrate in the renal sinuses is encasing the pelvic calcium system, but there is insignificant hydronephrosis in this case. And we can see the aorta as well as IVC here, and there is no involvement of the aorta and the IVC. And these are axial sections of the thorax. The first image is a CT image, and the second image is a correlative MR image. And in these axial sections, we can appreciate a minimal pleural effusion on the left side with associated subsegmental atelectasis of the left lower lobe. And in the heart, we can appreciate atrial thickening. The right atrium, it is thickened. And on correlative MR, we can see the type T2 hypointense right atrial wall thickening here. And these are sagittal images of the mediastinum. And here we can appreciate the first image is a CT image and the second image is an MR image. And in this image, on CT, we can appreciate homogeneously enhancing soft tissue infiltrate in the perivascular area. Just it is encasing the pulmonary artery. And on MR images, we can see the T2 hypointensity of this infiltrate. And on further reviewing our MR images done previously, we can also appreciate the T2 hypointense soft tissue surrounding the common carotid arteries bilaterally. And on post-contrast images, this soft tissue infiltrate, which was T2 hypointense, is homogeneously enhancing. And this is a sagittal image of the right lung. We can appreciate the oblique fissure as well as the horizontal fissure. And we can clearly see the fissural thickening. Usually fissures are not visualized on HRCT. And here we can appreciate the fissural thickening. And understanding that this is a multisystemic disease, we have further went with skeletal radiographs of the upper and lower extremities. And here we can see diffuse osteosclerosis. radius, ulnar, tibia, fibula, and as well as the femur, and also cortical thickening.
So now the house is open for discussion. Till now we discussed about the clinical scenario and the radiological investigations. So before going to the histopathology, I would like to contribute your contributions like what are the differential diagnosis?
Was the histopathology reviewed before all these surgeries would be done?
No, no,
The
no.
first histopathology which came with hematoma,
Yes.
was it ever reviewed?
Yes,
So
ma'am.
after that, after this MRI report, then we have reviewed.
After contrast CT
It was
chest.
the first right in the beginning, you have a tumor, which is tumor or whatever. It is proliferating, it's all over the place, and you're just focusing on it and like in the orbit actually.
Yes.
The disease is everywhere else.
But actually, initially the patient was presented with proptosis or the vision loss only. So we are thinking in the ophthalmic conditions. So the report came as lacrimal hematoma and orbital. So we are thinking about.
Chest X-ray done at that time.
Yes, ma'am. That time the chest X-ray was normal.
When you said it's IgG4 disease, you were thinking of it right from the beginning. Why wasn't the whole body, because it's a multi-system disorder, why wasn't the entire body investigated? Like your CT chest and abdomen should have been done at that time when IgG4 was suspected, and it is not confined only to
It's
the
not
organ.
her, it's like clinician perspective.
Then I'm talking about her also because she gave a differential diagnosis of IgG4. Did you?
Yes, ma'am, there were two differentials, lymphoma, pseudotumor, as well as IgG4. Even if it's a lymphoma, we have. Yes, ma'am. Even if it's a lymphoma, we have to investigate the entire body.
Yeah.
But that was not done.
Yeah, you are concentrated only on the head and neck when your differential diagnosis of lymphoma and IgG4 disease.
That's the problem of fragmented medicine.
Ophthalmology department, yeah.
Yes. Dr. Sucharita from SR from
I think this was being worked by the ophthalm department. This part of it should have been presented with them, and then
Yes.
because you said it is a learning experience for all of us, and it is. I mean, it would have been better that if they would have been there, and because it would have been more learning for them. Because next time they will get this patient.
Yes.
The patient came to them.
Okay, let's rest first now. Yeah, carry on.
When the patient presented, we had done chest X-ray, which was normal, and even ultrasound abdomen. And when serum IgG4, when one of the differential diagnoses, we had done serum IgG4, it was negative at that time. And if hematoma was the histopathological diagnosis, when on literature search, a hematoma has to be excised, has to be debulked as much as possible. So we had debulked on right orbit, and we planned for the other orbit also.
Is there any chance of dural metastasis in radiology? Any differential of dural metastasis?
So lymphoma can give dural metastasis, but that dural metastasis would be T2 hyperintense. And these are classic T2 hypointense dural based lesions that we are having. And T2 hypointense lesions as such in head and neck are very rare.
Any any residents from?
If we have a presentation of exophthalmos and ophthalmopathy, I think at least one thyroid function test must be done even before an MRI. It's cheaper and it could be coexisting. So we must rule out a thyroid disease, which was not done in this case. We still don't know the status of that thing.
Sorry ma'am, I don't think we have included that in the presentation, but his thyroid tests were normal. His thyroid function tests were normal.
Any other questions? So I think we can go back to the discussion.
So this is a multi-systemic histiocytic disorder, and
Let the you know this was a differential in radiology?
yes, sir.
Histiocytosis.
Yes, sir.
Let the pathologist present.
She has already
जो radiological classical findings है ना
Sir, the
mention and based on that you
clinically it was histiocytosis or
Sir,
not? And
based on
radiologically
based on imaging also we can diagnose it as histiocytosis.
But you didn't give that title
You
in
have
your
not shown it in the
in your
discussion
radiology.
partner.
Not even a single word about
histiocytosis.
which we thought would be likely. It's a lymphoma, most likely. Lymphoma like this. Even IgG4 can convert into lymphoma. Know that?
Yes.
I would like to work on myself, Dr. Bhartendu, junior resident from the Department of Pathology and Medicine. I am going to discuss the histopathological part of this case.
The first biopsy first. The first one plus.
Yes.
First.
We have received three biopsy symbol of this patient. The first biopsy came on the 10th of. The first biopsy came on the 9th of July. First biopsy came on the 1st of July 2022. We had other clinical differences was the lymphoma. We had received two containers. The container one was labeled as the right eye lymphoma. We received 4 grey white soft tissue pieces together measuring 0.6 into 0.5 into 0.4 centimeters. And the container 2 was labeled as the left eye lymphoma specimen. And in this we received 4 grey white soft tissue pieces altogether measures 0.8 into 0.5 into 0.3 centimeters. This specimen was processed and there is increase in the number of lacrimal gland. You can see here these acinar formations or the gland-like structures. We can see here these gland-like structure, acinar formations. Along with there is focal of these chronic inflammatory cells, predominantly comprised of these lymphocytes, dotted blue-like structures, and there was no atypical cells noted in all the sections examined. So we had our impression as lacrimal gland hematoma. Then again we received the second biopsy specimen on 18th of August 2022. At that time, their clinical differences was orbital hematoma, query malignant tumors. We received the specimen labeled as the orbital tumor excision biopsy. In this, we received 2 grey white, 2 grey brown soft tissue pieces measuring 2.8 into 2 into 1 centimeter. This specimen was processed and the microscopy shows, you can see here, the microscopy shows the dense fibrocollagenous and fibroadipose tissue pieces along with these thick-walled variable areas of thick-walled blood vessels, and these you can see here these are the inflammatory infiltrates predominantly comprised of the lymphocytes and a few histocytes, and a few muscle bundles, which were disorganized were also seen in this section. There was no atypical cell seen, and we had our impression again as the hematoma. The third specimen we received on the 10th of November 2022. It was very tiny biopsy measuring 0.3 into 0.2 into 0.1 centimeter, and the microscopy shows only this adipose tissue and fibrocollagenous tissue with focal areas of these dense chronic inflammatory cells, mainly lymphocytic components, and again there was no atypical cells seen. Since there was no improvement in the patient's condition, there was no improvement in the proptosis, the clinical radiological discussion was made among the Department of ENT and the pathology department. And this, the radiology was also indicated that the lesion was infiltrative. In view of the previous microscopic findings for the second slides, where we saw a variable amount of chronic inflammatory cells and thick white blood vessels, there was thought of that there is a deep tissue fungal lesions. So a review was done to look for any fungal elements. We did multiple deeper sections and a special stain pass was done to highlight these fungal profiles. All the slides were meticulously reviewed by two of our consultants, Dr. Asuk Singh sir and Dr. Prasad Durgapal sirs. But in this, the pass didn't highlight any fungal elements. Instead, shows aggregates of various areas of histocytes. In view of these clinical and radiological suspicions, along with the aggregates of histocytes, we had possibility of histocytic disorders, and we have ordered for multiple ISC panels. We have our, in this we can see here, these are the multiple histocytes. These are adipocytic components, and the past stain, special stain was done. This shows these histocytes, this bland eccentric nucleus with foamy cytoplasm. These areas were identified on the past stain. Based on these clinical radiological findings, along with these histocytic collections, we have our differentials as Langerhans cell histocytosis. Second is the dendritic cell sarcoma. Others are the Rosay-Dorfman disease, Ardheim-Chester disease, and the IG4 related disease. The various IC panels was done. These histocytes were positive for the histocytic markers like CD68 and the CD163. Other markers, CD3, CD20, CD38, and the CD138 was done. CD3 and CD20 highlights the various amounts of lymphocytic infiltrates, and CD38 and CD138 were also positive in the plasma cells. But IgG4 was also done, which were negative, so we ruled out any IgG4 related pathology. These markers were negative, like CD1A, Langerine, BRAF-B600E, CD30, ALK1, and IgG4. Based on these immunohistochemical markers, we ruled out our diagnosis. First, the Langerhans cell histocytosis, in which we have CD1A and Langerine are very specific, and it should came out at positive, but it was negative, so we ruled out Langerhans cell histocytosis. And even the nuclear feature of the histocytes have the multiple grouped nuclei, which was not there. It was some bland kind of nucleus. For the Rosay-Dorfman disease, the IC findings like CD1A and Langerine was negative. S100 OCT was also done, and which came to be the negative. So we also ruled out this possibility. For the dendritic cell sarcoma, we did S100, CD68, which were also negative. And there in this there should be the weekend variable expression of the CD68, but the CD68 was well taken up by the histocytic cells. And for the microscopic feature, there should be marked nuclear atypia in this dendritic cell sarcoma. But these all were not there, so we ruled all the possibility, and we have compared our findings with the clinical and radiological findings, and we have concluded our diagnosis as the Ardheim-Chester disease. About this disease, it is a very rare histocytic neoplasms. Earlier it was believed to be inflammatory lesions, but in the 2016 fourth edition of WHO, it was kept under the histocytic neoplasms. It is very rare disease. Till now, less than 1,200 documented cases have been reported. The patient's mean age was about 55 to 60 years, with male predominant. It is a multi-organ disease. The most common involvement is the skeletal involvement. Among this, the lower extremities, especially the tibia, is more commonly involved. On radiology, it shows the osteosclerotic changes already discussed by the radiological resident. And about the extra skeletal sites, the orbital involvement is also very common. It is seen in about 30% of cases, and among this, the proptosis is one of the most common features are seen. About the genetic profile, the most common mutation seen is the MAP kinase pathway gene mutations, most preferably the BRAF at the codon V600E, seen in more than 50% of cases. Other mutations seen are the PIK3KCA pathway gene mutation and along with the NRAS mutations. For the diagnosis of this AIIMS Chapter, a combination of clinical, radiological and histopathological features is essential to certain this diagnosis. The AIIMS Chapter disease, it is seen that in the 20% of cases it is associated with also the Langerhans histiocytosis, which we ruled out here. This table was taken from the American Society of Hematology. It has given some diagnostic criteria for the diagnosis of AIIMS Chapter disease based on these findings. Here we can see that all the criteria includes the clinical features along with the radiological features and then the histopathological features. So a combination of radiological and the clinical diagnosis is very essential in this type of cases. About the microscopy findings in this disease, there is the tissue infiltrations by the blend appearing histiocytes with this foamy kind of cytoplasm. A nucleus was bland, oval to indented and eccentrically placed, and the foamy or the gentomatous cytoplasms along with the lymphoplasmacytic infiltrates. Sometimes the Teuton giant cells are also seen, which are the multinucleated histiocytes. About the IC profile, these are positive for the histocytic markers like CD14, CD68 and the CD163. In 50% of cases, the BRAF mutation at codon V600E is seen. But these are typically negative for CD1A and Langerhans, which usually comes in LCH, Langerhans histiocytosis. Other common differences for this disease are the IgG4 related disease, LCH, and the Rosay-Dorfman disease. So I would like to conclude this that in the cases like this, the clinical findings and the radiological details are very essential to make a certain diagnosis. Okay, these are few of my references.
After immunochemistry report, we got the diagnosis of AIIMS Chapter disease. Hemato-oncology opinion was done. Patient was on steroid, advised to continue the steroid and planned to start cladribine. ECG was within normal limit and 2D echo was done, which shows normal LV systolic function with a left ventricular ejection fraction was 60%. Trace circumferential pericardial effusion was present. On 23rd of November, hemato-oncology review was done. Advised to start injection interferon alpha 5 million units subcutaneously 3 times a week for next 2 years. On 12th of December, the steroid was advised to continue. Steroid was advised to continue for next 7 to 10 days in a tapering dose, and injection interferon started. And after first dose of interferon injection, patient developed fever. For that, patient managed conservatively. During follow-up period, patient is on regular follow-up. Till date, patient received 18 cycles of interferon and patient condition improved dramatically. Patient still on interferon alpha therapy and chemosis and conjunctivitis resort. Bilateral vision is 6/6. Only mild proptosis is present. Discussion part. Erdheim-Chester disease is a rare non-Langerhans cell histiocytosis. All these things are already included in pathology slides. Clinical manifestations. It is a multi-system involvement infiltrating each and every organ system. The most commonly is a skeletal system, nearly 90%. CNS system, it's around 50% cases. And CVS is 45%. Orbital involvement, 25%. Only 1/4 of the patients are involved in orbit. Here the presenting complaint was in orbit. Orbital symptoms include exophthalmosis, proptosis, visual disturbance and diplopia. In bone, it's already mentioned, symmetrical diaphyseal and metaphasial osteosclerosis of lower extremities. Bone lesion can be detected with X-ray. But if it is not detected by X-ray, we can go for bone scintigraphy, CT, MRI or PET scan. Cardiovascular situation causes significant source of morbidity and mortality. Valve abnormalities, rhythm and conduction defects, periaortic fibrosis are the findings. The most common ones is infiltration into the right heart. Central nervous system, neurological involvement is seen up to the half of the cases. CNS involvement is an independent predictor of the worst outcome. Neurodegenerative cerebellar disease is the most common neurological complication. Pituitary involvement manifests as central diabetes insipidus and other endocrinopathies. In kidneys, it shows infiltration of the perinephric tissue like a mass-like lesion, may cause hydronephrosis, urethral narrowing, and slowly progressive renal insufficiency. It may be associated with the other myeloid malignancies. These are the signs and symptoms and radiographic manifestations we can see. In case of a CNS involvement, there can be ataxia, dysarthria, cognitive impairment, polyuria and polydipsia. In these cases, there will be parenchymal or dural masses, hypothalamic or pituitary stalk infiltration. During evaluation, we need clinical history and physical examination. Laboratory investigation includes all the CPC, CRP, ESR, liver function and kidney function tests, including serum electrolytes and hormonal assays. Imaging, CT chest and abdomen and pelvis, PET CT, MRI, echocardiogram or radionuclide ventriculography. Histopathology, including immunohistochemistry and molecular testing. Diagnosis is actually distinct histopathological finding in an appropriate clinical and radiological context. The differential diagnosis includes Langerhans cell histiocytosis, Paget's disease and Poem syndrome, hemophagocytic histiocytosis, juvenile xanthogranuloma, Rosay-Duffin disease. Central nervous system involvement can be confused for tumors. Cutaneous involvement can mimic vasculitis, cutaneous lymphoma, or cutaneous involvement with a Langerhans cell histiocytosis. Abdominal involvement, which can confused as primary or secondary retroperitoneal fibrosis, sclerosing mesenteritis, or retroperitoneal neoplasms. Cardiac involvement may mimic infiltrating cardiovascular disease. The management part is not every patient requires treatment at the time of diagnosis. Treatment can be reserved for patients with the symptoms or a CNS involvement or organ dysfunctions. Interferon alpha can be given for newly diagnosed symptomatic patients who are not eligible or not able to tolerate or not able to respond to the targeted agents or not able to get the targeted agents. Targeted agents which are available are vemurafenib, which is an inhibitor of BRAF V600E, and dabrafenib, is a kinase inhibitor active against BRAF V600E, and cobimetinib and trametinib, inhibitor of MAPK, extracellular signal transducer kinase pathway, which is treatment of Erdheim-Chester disease with a mutation of other signaling molecule where we are using cobimetinib and trametinib. Trametinib plus dabrafenib, which is in case relapsed Erdheim-Chester disease with an activating KRAS Q61H mutation. Other treatment modalities are glucocorticoids, which gives clinical activity, but there is no survival benefits. Cytotoxic chemotherapy include cladribine, cyclophosphamide, methotrexate, interleukin-1 receptor antagonists like anakinra or canagliflozin, sirolimus, infliximab, imatinib. Surgery and radiation has limited role, especially to manage local or the mechanical complications. These are the on which side these targeted therapy agents are working. So much.